We organize it on second Saturday of every month from 7 to 8 cm. So the motto behind starting this virtual CMEs are to keep ourselves academically active as well as to provide platform to all our brilliant neuroscientists to present on this platform. So this time we have Dr. Prakash Khaitan sir from Allahabad. He is a very fine neurosurgeon as well as multifaceted personality, a great poet, a writer. So he is in front of us to present his case about growing skull fracture. And our panelists and chairpersons are Dr. A.K. Singh sir, Professor A.K. Singh sir from Dehradun and Professor Kshitij Srivastava from Lucknow. So for further proceeding, I hand over the platform to Dr. Amit Gupta from GSBM Kanpur. Dr. Amit, please introduce our speakers and chairpersons.
Good evening, everyone. Good evening, respected AK Singh sir, and good evening, Arvind bhai. Good evening, Chitil boss, and everyone who is there. And it's a really honor for me to start this session. And
I think I request everyone, please mute yourself so that panelists and others can speak.
Yes.
Dr. Amit, please.
Yes. And I think the task that has been given to me to introduce the speaker and person is a very big task. And everyone knows about Dr. Khaitan, Dr. A.K. Singh sir, Dr. Kshitij Srivastava, and I think words are not enough for me to introduce them. Dr. Khaitan sir, एक बात बहुत पहले एक सीरियल आता था, टाटा स्टील वाले कहते थे कि वी आल्सो मेक स्टील. तो डॉक्टर खेतान के लिए ही इज अ वेरी गुड surgeon, poet, writer, good human being, and at last we can say he's a good neurosurgeon also. So we society social works also. And I will request Dr. Ketan sir to start his presentation.
Online payment ले मैं ले.
Thank you, sir. Thank you, Dr. Arvind Kankane.
Dr. Prakash, just a minute. Dr. Arvind. Dr. Arvind.
Sir.
Can you please ask the host to mute everyone except Dr. Prakash Khaitan?
Yes, sir. Yes, sir. I'm just, hello.
Yes.
Mute. I'm going to start the wonderful session initiated by one of the best friend Arvind Kankane, Dr. Amit Sharma from Kanpur, and it's my pleasure that I have two chairperson, Professor A.K. Singh sir, who is the legend in the field of neurosurgery, and I have also worked with him after doing my residency from KGMC. I was
अभी तुम लोग को बना दूंगा नाश्ता जब स्कूल लेके गए तुम लोग स्कूल भी रेड मिला हमें नहीं वाइट था बेटा मैंने भी खाया
I continue, sir.
Host, kindly mute everyone. Kindly mute everyone, Dr. Prakash Khaitan.
Again, I'm going to start. Kindly mute your mobile. We are getting lot of hindrance. And I'm giving congratulations to Dr. Arvind Kankane, Dr. Amit Sharma. And it's my pleasure that I have Professor A.K. Singh sir. I have a huge respect for him. I've worked with him. And I've seen the many but we did our MCH in the same batch from KGMC. And it's my pleasure that he is being with us. He is one of the most eminent professor, academician, and a neurosurgeon, not only in the UP, but in our whole country. He used to call for lots of examination at various places. It is a matter of great pleasure, great respect for being a batchmate of Dr. Chitij. Sir, today I am going to start growing a skull fracture. As you know, there are 8 bones which makes the skull. Sphenoid bone, frontal bone, parietal bone, temporal bone, occipital bone, ethmoidal bone. And this is the bone that is the most common bone where the skull, growing skull fracture grow. We also called growing skull fracture enlarging skull bone. It is another name, enlarging skull bone. So these are the 8 cranial bones. I will start my topic from various fractures we encountered in daily routine practices, either as a neurosurgeon or a neurologist. A skull fracture is a break in one or more of the 8 bones that form the cranial portion that I already taught you. Any significant blow to the head result in concussion with or without loss of consciousness. Skull fractures. Skull fractures can generally be categorized into open versus closed fracture. Structurally, it can be linear, it can be displaced, it can be depressed, or it may be comminuted. Most fractures are treated conservatively, most of the fractures without operative management in the children. However, you must remember, open fractures, significantly depressed fractures, and those that involve the posterior wall of the frontal sinus with dural disruption and CSF leak may require surgical repair. In children, the bones typically remodel quickly, but these are 3 to 4 kinds of fracture in children which we must repair, like open fracture, significantly depressed fractures, those which involve posterior wall of the frontal sinus, dural disruption, and CSF leak may require a surgical repair. You cannot ignore it. Furthermore, frontal sinuses typically don't start to erect until age 4 to 5 years, and thus frontal fractures in young children can be managed conservatively because sinuses are often not involved. Again, a young children with thinner and softer bone can have a small area of depressed bone referred to as ping pong fracture. This is a question used to ask in our MCH examination, what is the ping pong fracture? This is young children with thinner and softer bone can have a small area of depressed bone referred as ping pong fracture. In this fracture, a burr hole can often be placed adjacent to the fracture and an instrumental slide underneath to elevate and fracture from inside. Or fracture can be elevated percutaneously, applying outward pressure with a screw temporarily inserted in the depressed bone. These are the 2 techniques we use to elevate this type of the fracture. Sometimes we get little bit hemorrhage. Sometimes we get torn off dura membrane over the brain also, but it should be done very meticulously. In 0.1% of patients with linear fracture that are generally followed conservatively owing to the continued growth of the skull in childhood, a fracture can actually expand in size over the time and cause noticeable defects. Now I am coming to the growing skull fracture. We are also called it enlarging skull fracture. Enlarging skull bones. Obviously, growing skull fracture or enlarging skull bone, it is not seen in adulthood. It is seen before the age of 3 years of the age, most common in infant group. These growing skull fracture are always associated with a dural tear. Often, dural edges retract under the growing bone defect. This is retraction of this dura creating lots of problem while operating it. We have to sacrifice lots of bone, or we used to make a flap of bone around the dura to get the margin of the dura. Therefore, we can repair it meticulously. But growing skull fracture are always associated with dural tear. Thus, the dural defect is larger than the skull defect. Just mind it. The dural defect is larger than the skull defect noted on the surface. It is important to find these edges and close them with or without a patch. The skull defect can be repaired using grafts such as calvarial split thickness graft, various facial atta we can use. We can use facial atta commonly used. We can nowadays we are using surgical grafts also. These are commercially available. There is a story behind development of this surgical graft. Started in the KGMC also. I will tell you. Setting cranioplastic material and morselized bones. Most commonly, we are using a flap adjacent to the skull bone from the scalp or from facial atta, or using a commercial available commercial graft. There are so many types of skull fractures. In cranial vault, linear fracture, also called fissure fracture, depressed fracture, elevated fracture, comminuted fracture. Here we have also pond fracture, sutural diastatic fracture. We have skull base fracture, that is called basilar fracture. Growing skull fracture, already I have told. Fracture of skull bone, skull base, cranial burst fracture, ring fracture, ACE fracture, MCF fracture, and PCF fracture. Just see anterior cranial fossa fracture, posterior cranial fossa fracture, and these are the some pictures of the types of the fracture. This is the linear fracture. This is the skull X-ray view. This is the 3D view of the skull bone. This is the depressed fracture. Just see, it is not a 3D image, therefore it is not appreciated, but you can appreciate in this. This is the basilar fracture. Just see, PCF, just I have told you, posterior cranial fossa fracture. You can appreciate in X-ray also. This is communicated fracture. This is the sutural diastatic fracture. Just see. Now I'm coming to compound fracture. A fracture in conjunction with an overlying laceration that tears the epidermis and the meninges, all the layers, epidermis and the meninges, or run through the paranasal sinus edge and middle ear structure, bringing the outside environment into the contact with the cranial cavity is called compound fracture. Fracture which communicate with the outer environment is compound fracture. Compound fracture can either be clean or contaminated. Compound elevated fracture, it is very rare. All the time we see compound depressed fracture, but in literature we have also seen some cases of the compound elevated fracture. Therefore, it is important to tell about the compound elevated fracture here also. It is a rare type of skull fracture where the fractured bone is elevated above the intact outer table of the skull. Just see. This is the type of the depressed fracture. Just see it. This is the breach in the dura. Also, you can appreciate it. The scalp, the 5 layer of the scalp also get teared, and it is communicated with the outer environment. Therefore, we call it compound or communicated fracture. It is compound with the outer environment. The inner environment or inner ecosystem of the brain communicate with the outer ecosystem of the environment. This is the communicated fracture. Just see it. The linear fissure fracture. I am coming linear fracture that are breaks in the bone that transverse the full thickness of the skull from the outer to inner table, usually with no bone displacement. There is no bone displacement. But you have to be very cautious while dealing with the linear fracture. They are causing lots of problem in adulthood, in adult in growing child. Therefore, it is very important to mention the simple linear fracture. Although there are full thickness, there are no displacement, there is no loss of bone. In spite of that, they are causing lots of problem. The common cause of injury is blunt force trauma, where the impact injury transferred over the wide area of the skull, not easily detectable in radiology. Most common type, line fracture, run parallel to the axis of compression. It is the most common type of the fracture. You used to operate EDH, and after removing the scalp flap, we used to see the mild linear fracture. It is not appreciable in CT scan. It is not appreciable in X-ray. In spite you get while you are operating. Line fracture runs parallel to the axis of compression. Linear skull fracture are usually of little clinical significance unless they parallel in close proximity or transverse a suture. They involve a venous sinus groove or a vascular channel. The resulting complication may include suture diastasis, venous sinus thrombosis, or the usually we get epidermal hematoma. In young children, although rare, the possibility exists of developing a growing skull fracture. Therefore, it is very important to mention it while giving lots of things about growing skull fracture. We should know what is the significance of linear fracture, how it can be turned into growing skull fracture in adulthood, and what are the complications of a simple linear skull fracture if it is not treated in infancy or childhood. What are the complications? Therefore, it is necessary to describe it here. Just see, this is the linear skull fracture. Depressed skull fracture, I have already told about it. It is a fracture, a large signature, since it reflects the type of weapon used. A depressed skull fracture, a fracture, a large signature, but nowadays we are not getting any benefit, either anti-mortem or post-mortem injury. Nowadays, I think we hardly get any reflection of type of weapon. I will try to get attention from my chairperson and their experience, because I have not seen a signature of weapon while operating or treating a patient till now. It occurs if the fracture bone is driven inward to distance equivalent to the thickness of a skull table, sometimes only involve outer table. Risk of post-traumatic epilepsy is quite high. It is around 15%. Therefore, we cannot neglect it. Depressed skull fracture present a high risk of increased pressure on the brain or a hemorrhage to the brain that crushes the delicate tissue. In complex depressed fracture, the dura mater is torn. Just see, this is the compound depressed fracture. And the post-traumatic epilepsy, there are delayed onset seizure. There are two types of the seizure: post-traumatic, early onset and delay onset. Delay onset seizure are persist for a long time, while early onset seizure, they usually subsides within 3 months. But the delayed onset seizure, they last for more than 3 to 5 years. Therefore, it must be treated. If dura is torn, it must be repaired. Dura may be repaired, or CSF may be stopped spontaneously, but a depressed fracture may cause post-traumatic epilepsy, delayed onset for a quite long time. Communicated fracture, a spider web or mosaic fracture, 2 or more intersecting lines of fracture dividing the bone into 3 or more fragments, cause significant force striking over broad surface area. These are the communicated fracture. Just see multiple communicated fracture. Just see the multiple communicated fracture. Just see. It is a very broad area. Just see the involvement. Just see. Bone fracture is smooth concave. Just mind it. Smooth concave dent resulting from in buckling of the skull. Occurs in pliable skulls less than 4 years of age. Inner table is not fractured. In bone fracture, you will not get fracture of the inner table. Brain and meninges are not damaged. Cause is obstetric fracture and forcible delivery. Again, I would like to get attention from my chairperson whether bone fracture causes any seizure attack in future or not. Since as far as I am concerned, I have seen many literature. On fracture, I have not get any literature that it is causing any seizure activity. But if you have any experience, please share with us. This is the bone fracture, just see it. This is the bone fracture, just say it. Gutter fracture. Gutter fracture nowadays it is very uncommon since it is a fracture in which outer table of the skull bone get removed. It is found in the obliquely bullet injury. If a bullet injury is going to happen obliquely, then we found gutter fracture. Part of thickness of bone is removed from to form a gutter, cause oblique bullet wound associated with the irregular depressed fracture of the outer table of the skull. Dura and brain may be torn. Dura brain may be torn either due to gutter fracture or due to the heat caused by the bullet injury also. One thing I would like to mention it, in gutter fracture, inner table is not getting fractured, but dura and brain is also get some type of the injury due to the heat produced by the bullet during the creation of a gutter. This is just see the inner table, just see the outer table. This is the gutter fracture. There is a huge amount of heat generated here. Diastatic fracture, separation of suture due to blow on the head with blunt weapon. Young children, most common is sagittal suture. Widening of the suture may be appreciated on plain radiograph and better still appreciated CT scan. Following width are considered to be diagnostic of structural diastasis. More than 10 mm at birth. Just see the picture. More than 10 mm, more than 3 mm at 2 years, and more than 2 mm at 3 years. This is the sutural diastasis. Most common is sagittal suture. Here metopic suture is spared, but you see this the sagittal suture and lambdoid suture is involved here, and it is a separate fracture here. Sutural diastasis apart from a linear fracture of the frontal bone. Growing skull fractures are rare and occur almost exclusively during the first year of the life. There has been disagreement about the cause of these lesions, a fact reflected in the number of terms that have been used to describe them. There are lots of terms used for growing skull fracture, enlarging skull bone, traumatic ventricular cyst, craniocerebral erosion, craniomalacia, leptomeningeal cyst are the common names which used for describing growing skull fracture. Sufficient bone must be removed to allow the dural edge to be identified, and dural closure is must be accomplished. This can be on the occasion a more formidable task than might be expected. Yes. Growing skull fracture, linear or non-linear fracture of the children that enlarge with the time and are termed growing skull fractures. Growing skull fracture are rare and occur almost, then I am repeating my line, also describing a traumatic ventricular cyst. They appear most frequently as soft gallial collection. Just see it. They appear most frequently as soft subgallial collection overlying an enlarging bony defect at the site of previous diastatic fracture. However, the name growing skull fracture are easily recognized. They appear most frequently as soft subgallial collection. You get a bony defect around it, and that is the if you palpate it, you just get a subgallial collection. It is a soft, and you get a bony defect around it, and you can also appreciate some CSF material is there. I don't know, sir. Dr. Tandon sir is there. Dr. A.K. Singh sir is there. When the neurosurgery was growing, when CT was not there in KGMC, it was growing like a small child. Sir, you have grown the neurosurgery not only in the KGMC but gradually in the whole country. Trans illumination has role in detecting skull fracture. I also like to get an answer from my chairperson, or experience while making a diagnosis when the era of CT scan was not there in KGMC. Just see the classification of the growing skull fracture. Classically, growing skull fracture are primarily grouped as a leptomeningeal cyst type, in which arachnoid herniates into the subperiosteal layer via bony defect. Just see. B, brain evacuation type, in which the brain tissue herniate in this layer. This is the brain tissue herniate in this layer. And type C, the present case is not classified as either of these. Cerebrospinal fluid and brain tissue have herniated into the interperiosteal space. These are the three types of the growing skull fracture: A, B, and C. Classification of growing skull fracture, again, the three main type. This is the type 1. Just see it. This is the type 2. And this is the type 3. Just see it. The thing that I've already told you, type 1, type 2, and type 3. Durocranioplasty was the correct technique in the type 1 cases. A shunting procedure required as an initial or definitive management of the type 2 and type 3 fracture with raised intracranial pressure. I personally did shunt in 2 cases of growing skull fracture in KGMC, but in my practice I didn't have any experience regarding any shunt procedure in growing skull fracture. Sir, history and pathogenesis. Housey was the first to report a patient with growing skull fracture in 1816. He has described a 9-month-old child in whom, after an injury, an enlarging defect of the parietal bone developed. The parietal bone is the most common site of the growing skull fracture. The defect was apparent within 2 weeks of the injury and never resolved. The boy was re-examined when he was 4-year-old, and the opening in the cranium remained undiminished. Upon laying the hand on the part, pulsation of the brain were felt strong and distinct. First account of the pathology of this condition was Rokitansky in 1856. He reported on a 5-month-old child in whom an enlarging skull mass developed after he had struck his head during a seizure. Therapeutic puncture of the mass performed, after which meningitis occurred and the child died. An autopsy, a large bony defect was found along with an associated dural tear and injury of underlying brain. Sporadic accounts of similar cases were published over ensuing 50 years. Although the pathogenesis of growing skull fracture remained obscure, there was clear understanding of the salient clinical features of the lesion, as Goodley wrote in 1885. The fracture referred to can apparently only occur in young children. It is a simple fracture accompanied at the time of accident by what appears to be an ordinary hematoma beneath the periosteum, but this hematoma is noticeable either immediately or after a lapse of certain time to pulsate. Eventually, it is found that there is an aperture of considerable size in the skull, and if the child dies, don't not only the dura matter discovered to be ruptured, but in many, if not all cases, brain itself seen have suffered a serious injury. Acting on this knowledge, Sir Charles Balance performed the first repair of the growing skull fracture. Subsequently, a great deal has been written about the growing skull fracture, much of which is concerned either directly or indirectly with defining the pathogenesis of the condition. Essentially, all the writers have recognized that a dural laceration is necessary for development of enlarging defect. There has been disagreement about the relative importance of the leptomeningeal and parenchymal injury, the microscopic anatomy of the site, and motivates forces that causes fracture expansion. I will clear a slide in the end of this lecture in which brain tissue get herniated. It may be also a symptom or sign. Brain tissue get herniated from a separate laceration over the scalp. The site of fracture is somewhere else, while the herniation of the brain tissue somewhere else in the lacerated scalp. I will definitely show you this slide. There has been a disagreement about the relative importance of the. Therefore, I am not well satisfied with this statement of humans. Dyke introduced the term leptomeningeal cyst. Lots of cyst I have already told. Dyke ने इसको leptomeningeal cyst has told he has told leptomeningeal cyst in an article that dealt primarily with the radiographical characteristic of this lesion. He suggested that after a fracture with an associated dural tear, lobulated fluid filled a passage from cyst, and owing to pulsation of the brain, the overlying bone is absorbed. Pathological data confirmed this hypothesis was not presented. A similar idea was offered by Toeras and Ranshoff in 1953. They reviewed that the experience with 7 patients they have operated in over a 20 year of the period. All 7 had been broad dural laceration with the cystic lesion underlying the cranial defect. This investigation through that the cysts were caused by cerebrospinal fluid that became trapped in a herniated section of the arachnoid matter and enlarged by means of a ball valve mechanism. Presumably, the cyst prevented bone reapproximation, and because of their increasing size, the pulsation of the underlying bone led to bone resorption. Other observations have not confirmed the central role of the leptomeningeal cyst in the pathogenesis of growing skull fracture. As a part of larger discussion of the skull fracture, Panfield, a renowned neurosurgeon, described a patient with an enlarging defect at the site of the childhood fracture. At operation, brain, but no cyst was found in the defect. Some other scientists also described herniated brain within the ossification defects in the children and growing fracture, and highlighted the importance of local brain injury and swelling of the fracture developed. Definitely, the local brain injury is there in many cases. Additionally, these writers made the point that porencephalic cyst can be seen in the parenchyma adjacent to the fracture site. This common predicts the result reported by Roy and colleague, who looked more specifically at the microscopic anatomy of the growing skull fracture. They have operated 7 patients and presented a detailed histopathology from the group. They found that brain was abnormal in every case. In every case, just mind it. In out of 17 cases, they found brain was abnormal in every case with area of gliosis often admixed with the focal area of necrosis and what seemed to be a combination of old and new damage. Cystic degeneration was very common. These researchers concluded, in inverted comma, leptomeningeal cyst formation emphasized by some workers does not take place or is extremely rare. Cysts observed in such cases generally result from the absorption of necrotic bone followed by the gliosis. There are other lots of scientists did research in this field. They performed craniotomies and found that both dura and arachnoid had been opened to produce an enlarging fracture. That concomitant injury of the brain did not increase the likelihood that a growing fracture would develop. Clinical confirmation of the finding that dural or arachnoid laceration without brain injury is sufficient to cause an enlarging skull fracture from a study of Winston and co-workers. Therefore, the theory of there was a big question mark from the previous scientist who has given a theory of bone resorption after a study of the Winston and co-workers. These investigators described 4 patients in whom growing fracture developed after craniosyntestis repair. In only one of the children had a dural laceration been recognized at the time of first operation. None had any reported parenchymal injury. At repair, all the 4 were found to have broad dural defect with brain herniating through them. 2 of the 4 children experienced seizure. What are the post complications? And one of them to become hemiparetic more than a year after first operation. The investigator think it is likely that these problems were secondary to the injury caused by the progressive herniation of the brain through the dural defect. Similar findings were noted by the G-men and associated in the review of the craniosyntestis patient presenting with the growing skull fracture after surgery. They also identified risk factor and could give rise to leptomeningeal cyst formation after craniofacial procedure. This concept of delayed or secondary injury is of importance in the patient of growing skull fracture, although many of the children described have had significant neurological deficit. From the time of their injury, there are several reports of progressive dysfunction that develop months, even years, even in adulthood. After third or fourth decade, this dysfunction has been attributed to brain injury caused by local brain herniation and consequent ischemia. Repetitive trauma to the exposed bone on the bony edge or direct concussion. Physical distortion of the bone related to the displacement. The Winston's reports offers important evidence that such injury can in fact occur even in the absence of significant pre-existing bone damage. Given histological description of ongoing injury to both the bone and brain in this group of the patient, there is a strong reason to believe that the secondary injury is clinically significant problem. Yes, we must consider any linear fracture, depressed fracture in a future growing skull fracture and future complication in an infant or a children, and must try to stop it. Either we are practicing as a neurosurgeon or a neurologist. Growing fracture occur in only setting in which there is rapid brain growth or much less commonly increased intracranial pressure. Several writers have speculated on the importance of tissue pulsation in the development of these lesions, but there are little evidence to suggest that isolation of the tissue pulsation is sufficient to cause fracture to enlarge. There are lots of slides. I am getting little much time, Dr. Arvind. In spite of that, I am trying to complete the task that you have given me. Enlarging skull fracture are extremely uncommon, as we have made already the discussion. They account for less than 1% of the skull fracture in large pediatric series, and for practical purpose, they are never seen in adults. One thing I would like to share you, we don't have any Indian study regarding growing skull fracture. We have not given so much importance of growing skull fracture or leptomeningeal cyst. Therefore, we don't have any data, Indian data. It might be more than 1%. Almost all the enlarging fracture are in children less than 3 of the age. 2/3 of them occur in the children less than 1 of the age. Parietal region is the most common site. No specific or unique mechanism of injury predisposes patient to develop a growing skull fracture, but in many cases, trauma suffered seems to be relatively severe. This severity likely to account for the frequency and severity of the neurological deficit found in this patient. More than 50% more series for the incidence of post-traumatic seizure. That is the most common find. And some growing fontanelle due to underlying leptomeningeal cyst have been reported in children without a history of significant trauma. In these children, dural injury apparently occurred during delivery. Timely detection of the patient with growing fracture requires culling those at risk from among the much larger group of the children with simple skull fracture. Typical patient of a growing skull fracture has following characteristic. Youth. Almost all the patients with enlarged fracture are younger than 3 years and clear majority younger than 1 year. A subgaleal fluid collection which may or may not be pulsatile, overlying fracture, although the collection may resolve soon after the injury. Presence of neurological deficit caused the injury. It might be possible, might be present or might not be present. A skull radiograph that demonstrates a diastatic fracture, dural edge separation at least 3.5 mm. Recommendation vary as to how best to follow patients in whom a growing fracture is likely after they have been identified. अब क्या क्या रिकमेंडेशन है, हमें कब बच्चे को देखना है, कब उनको फॉलोअप में बुलाना है, अगर हम कंजर्वेटिव ट्रीटमेंट करते हैं तब. Some writers have been advised obtaining skull radiographs 6 weeks, again several months after the injury. It seems equally reasonable to see these patients in clinics after 8 weeks. By this point, almost all growing fractures can be recognized on physical examination. In affected patients, there is a palpable ossification defect. Palpable ossification defect, I am again repeating it. Palpable ossification defect larger than that initially present if you compare from the previous X-ray or CT scan, usually but not always overlaid by a soft, often pulsatile subgaleal collection. Just see. Radiographic monitoring of the growing skull fracture. A parietal skull fracture easily seen on the lateral view of the skull. The skull fracture obtained a month after shows that the fracture has become very wide. Just see it. Fracture become very wide. Owing to leptomeningeal cyst, continued pressure, erosion of the bone. Nowadays, we are not evaluating with X-ray. We are directly getting a CT scan done, and it is very easy to recognize the enlarged defect of the bone. Classification system of the children with growing fracture have been proposed but have been little clinical impact. All such patients require operative repair. In other patients, ossification defect is a small or only minimally different from its appearance at presentation. No overlying collection is present. It is probably best to re-examine these children several weeks after a fracture may heal without intervention. This group includes handful of the patients who have been described with what termed as pseudo-growing fracture. In these cases, fracture that has enlarged slightly in the weeks immediately after injury, ultimately healed after a few months. Finally, a child has no skull defect 2 months after the hurt. It is quite unlikely one will develop, and family can also so informed. A number of patients of growing skull fracture have been described who were not identified or treated under years after injury. Each had a large skull defect usually, but not always, with an overlying fluid collection. Common presenting complaints were the pain at the fracture site, epilepsy, progressive neurological deficit. Interesting that although some writers have suggested growing skull fracture eventually stabilizes and ossification defect stops enlarging, and others have not found this to be true. I would like to also ask from my chairperson about their experience, whether this theory is true or not. I would like to ask from BK Oja sir. Sir, you have seen lots of cases. Professor AK Singh sir, because at the time of our teaching, it was also taught. In some cases, it spontaneously stops. There have been several reports of the patient who have had enlarging bone defects and worsening neurological condition more than 10 years after injury. Now, radiology, it is obvious. The radiological growing fracture has been well described. On plain radii appear as a smooth edge ossification defect, often sclerosed, occasionally depending on their age with sclerotic margin. CT scan demonstrates some same bony abnormality almost uniformly, injury, cystic degeneration of the underlying brain. Frequently, brain is seen to protrude into the fracture. Ventricular asymmetry, yes, you just see the ventricular asymmetry is also found. Since CSF of brain is herniating there, ventricle drawn toward the fracture site. MR generally add little, but a clear delineation of the brain parenchyma, although CSF may occasionally be identified going through the bone defect into the subgaleal space. Some other scientists describe that use of color Doppler or B mode of the ultrasonography, the detection of dural tear that may be missed on the initial CT scan. The clinical importance of these findings are unclear. Angiography is minimal value. Just see it. Just see the radiological appearance. This is the side. This is the side. Just see. These are the 3D images, which also depicts the same thing. Now we are coming to the treatment part. Treatment of the growing skull fracture is only operative. Successful repair requires identification of dural margin. Although there is a loss of lots of bone, while we are defining the dural margin, what happened after the tear of dura, it gets shrinks and it gets beneath the overlying bone. Therefore, we have to either remove lots of bone, or we have to make a separate flap of the bone all around. That is the best way to prevent the loss of the bone also. The repair of the dural defect and coverage of missing bone. There is no place of minimal invasive technique with this condition. A large incision is needed. Yes, incision must be large. It may be 2 or 3 times more than the cyst, incision of the cyst. It must extend well beyond the margin of the skull defect. The skin flap is reflected in subgaleal plane and the bony defect is defined. The dural edge has a tendency to recede and often located well back from the bone edge. It can be found progressive removal of the bone from the margin of the defect until the dura is circumferentially exposed. Alternatively, a burn hole can be placed a few centimeters from the bony edge. A circumferential craniotomy is often performed, and it is preferred. Rather, I will use the term preferred, which allow identification of the dura around the entire lesion. Once the dural defect is exposed, the underlying bone is carefully dissected. A large area of cortex herniated through the dural defect. An attempt to reduce it should be made. Some writers advocate resection. These are the many of the times I have seen these are the gliotic bones, and we have to sacrifice it. But again, I would like to question with my chairperson and senior person what we have to do. Many times it is very difficult to cover the flap or the herniated bone in spite of repair with the dura. Closure of the dural defect is necessary to prevent recurrence of the growing skull fracture. Primary closure is never possible as some graft material must be used. Although there is a theoretical advantage of use of the local tissue, for example, pericranium, repair with commercially available substitute is often easier, seems to be clearly. Sir, I would like to share one thing, Dr. Kankane sir, Dr. Oja sir. The first surgyware company, one of the member of the surgyware company came in the KGMC, and first time they have started using surgyware graft. And our respected head of department, sir, Major Hussain, sir, given 5 to 6 message to us, he just go and apply in some cases. So it was the first case in which Dr. Manjar sir were there, and I was assisting him. And it was a large case of leptomeningeal cyst. Whenever you see the advertisement of surgyware of this kind of commercially available patches, there is a photographs of that repair of the leptomeningeal cyst, in which we have not made a burhole. We are at that time not preserved the bone, but we have identified the whole margin of the dura and repaired it with the surgyware dural graft for the first time. And in the advertisement is still there, showing that photograph also. Use of subgaleal tissue graft for duroplasty has been described by some Abujad and co-workers. They suggested dissection of the subgaleal plane may prevent injury of the brain tissue adherent to the underside of the galea. It should be emphasized that the entire dural defect must be identified and repaired, or problem will reoccur. There are several other options for bone coverage. Must be split thickness calvarial graft, full thickness calvarial graft, synthetic material, split ribbed graft. All of these techniques have been inherent advantages and disadvantages, and each appreciate for some patients. It does appear that if the dural closure is good, rotate the total bone coverage is less important, and in that setting, defect eventually fills in with time because of the osteogenic potential of the underlying dura. Just see it. Repair with the dural graft. We have did lots of cases with Dr. Chitij also, but we have not preserved the photographs. They are wonderful photographs of the growing skull fracture. Just see the growing skull fracture. This is the dural margin, and this is the craniotomy, and this is the graft and craniotomy. Although essentially all writers favor operative repair of the growing fracture, one group has suggested that it is not always necessary. Ramamurthy described 4 patients with non-progressive diastatic fractures. None of the fracture healed. All 4 of the patients were left and with the ossification defect, but none of the patients had progressive neurological problems. ये तो भगवान भरोसे वाली बात थी. The size of the population from which these patients are drawn cannot be determined, and no identification is given as to how to decide with fracture will stabilize over time. In any case, a spontaneous closure of the skull defect did not occur. Finally, placement of a shunt is the best result for the patient with clear evidence of the hydrocephalus and not thought to replace or alter the need of operative repair of these lesions. Simultaneously, you can do both surgical repair of the bony segment with a defect with duroplasty, and sometimes shunt surgery. Both is required because the bulging of the brain tissue is so much that in spite of dural defect, the repair of the dura, it is unable to put a flap of the bone over the skull bone. Open test, however, one paper described two children with the hydrocephalus and growing fracture. Both were treated only with the shunt and both the bony defect is resolved. Conclusion. Growing skull fracture are rare. They almost always occur in children younger than 3 years. The inciting injury is often relatively severe and associatedly neurological disability is common. A skull radiograph obtained soon after injury demonstrate fracture diastasis more than 3.5 millimeter. CT often shows the injury of the underlying brain. A pulsatile subgaleal collection is frequently present. If the untreated, the ossification defect often widens the ensuing weeks and months. Once diagnosis is clear, operative repair is indicated. A large craniotomy is often required because the dura can retract several centimeters from the bony edge. Identification and repair of the bony defect is required if recurrence is to be avoided. If unrepaired, growing fracture can be continued to enlarge and secondary brain injury and dysfunction in the form of post-traumatic seizure, progressive neurological deficit, hemiplegia may occur. This is a very interesting case, Dr. Kankane. I am going to present. It is a small children get a cycle injury. He fall from a cycle, and it was the mode of injury. And this was the small tissue. Just see, found over the scalp. There is no other laceration found anywhere. It was misdiagnosed by some quacks also. Fortunately, it came to us. It is nothing but it is a blood mixed CSF. Just see it. Along with it is a brain parenchyma. It is the fracture site is there here, but since the incision was there, laceration was there, and there was a pressure in intracranial pressure was so much high, it herniates from here and comes out from the skull along with the CSF. Just see it. And this is the preoperative image. Just see how much the bone is found inside. The little bit contusion or contusion of the inside brain also here. Just see how much bone and how sharp the bony pieces was there. We have repaired it and fixed with the, nowadays we are getting very good quality of titanium small plates. We have fixed it. Again, my question with chairperson sir also, whether we have to fix it with plates or not, since guardians always ask a question whether you have to whether the plates will remain for lifelong. We have not we have not got the absorbable plate, therefore we have used non-absorbable plate. And this is the post-operative result. The correct alignment of the bone. In spite of that, we will follow it every 3 months to see whether the bone inside growing or we are getting any defect inside the bone also. Thanks, sir. Thank you very much.
Thank you, Dr. Kedan, sir, for nice and elaborative description of growing skull fracture. It was definitely informative for neurosurgeons. However, neurologists also get something about this topic. So I request our panelists, Dr. A.K. Singh sir and Dr. Chitish sir, to say something about this, to give their expert comment about growing skull fracture. A.K. Singh sir, please.
Prakash, very informative, very detailed, very informative.
Thank you, sir.
Arvind, I wanted to know one thing. Are there any students here? Any
Sir, no, sir, students are not here. I think it was not circulated to students also. So I think I'll keep this thing that I circulate this to students also.
Because if the students are not there, then in that event, the focus becomes different. The management.
I'll ask from KGMU and other institutes to circulate this among students also. From next time onwards, I'll keep this in mind.
Very good evening. It was circulated among the students, but they are probably not interested in academics.
This happens, sir.
That was a very, very disheartening comment. But true.
Sir, the things are changing.
Yes, yeah.
And they are choosing their branches where there is no work, there is no hard work.
True.
And when most of them who are coming to neurosurgery kind of branches, they do not want to do any hard work. We are facing a lot of problems.
Yes. Okay, that's a topic for discussion next time. Anna, I think we should discuss that kind of a thing also. When there are no students, we should discuss that kind of a thing. Okay, couple of queries to Prakash, a couple of comments. One was about that you asked whether trans-elimination was done in our days or not. No, it was not. The way we did it was because it was a pre-CT era. Therefore, what we would do is that we would follow a patient up clinically and with radiology, with plain X-rays. If the fracture seemed to be increasing 6 months or 6 weeks, 3 months, etc., then we would go in and operate. That is a situation at that point of time. Trans-elimination does not work because primarily, most often, it used to be a bulge which would often settle down when the child would sit up. So that was one part. Number two, you made a comment about Professor Ramamurthy. Now, about the conservative treatment, as you mentioned, that if you do a shunting, then sometimes these things do settle down. This was the senior Dr. Vesh, Dr. N.D. Vesh, had a large experience of many patients having been treated of meningomyelocele, encephalocele, and growing skull fractures treated with shunts. As usual, we Indians do not publish, so he also hasn't published. But this is a one-to-one communication. Okay, now I have a couple of questions for you, if I may.
Sure.
What would be your investigation of choice in today's world, whether it'll be a CT or an MRI? That's one question. Number two, why is it that these growing skull fractures happen dominantly in the parietal lobe, the parietal bone region?
Sir, that is the most common site. Why it is happened in the parietal region, which is the most most projecting part of the skull, and the most one of the part of the skull which get encountered most commonly, I think, during an accident or trauma.
We strike our foreheads often enough. We have a lot of fellows who come with craniofacial injuries, etc., etc. Yes. And children also, they fall face down. But for some reason, you don't seem to encounter growing skull fractures in frontal bone as often, or comparatively much less rarely.
Yeah, right.
What would be your investigation of choice, CT or MRI? I remember having read somewhere that MRI is the better choice.
Sir, MRI the MRI the choice of the investigation, because it also delineates the parenchymal injury of the brain also, sir, apart from bony and dural injury.
So that will be your investigation of choice.
Yes.
Okay. Right. Thank you. That's all. From my side, that's all.
Please. Thank you, sir. Thank you very much for your comments.
Sir, I have a question, if I am permitted, sir.
Sure, sir.
Definitely, sir.
What is approximately, Dr. Khaitan, how many cases you have seen, or any one of us seen this leptomeningeal cyst, I mean the growing fracture with hydrocephalus? I have yet to see a patient of this entity with a hydrocephalus.
The 2 patients we have seen, sir, while doing our
Right.
studying in MCH in KGMC, in which we did shunt surgery.
No, so what possibly you think was the cause of hydrocephalus related to injury? What was possibly the cause of hydrocephalus associated with growing fracture?
Right question. It is a good question you have asked.
Then one small funny question also has developed in my mind right now. Now, the human body has got so many bones all over the body. Why it is growing fracture only in the skull bones and not elsewhere?
Since intracranial pressure is, I think, is associated with the growing skull fracture, it is might be, sir, might be intracranial pressure.
The way I would like to answer it is like this, if I'm permitted. See, cranial bones are not an ordinary bones. They are container and they contains an organ. Now, other bones of the body like femur, humerus, they do not contain any organ of the body. So, and the brain, as we all know from the birth, it keeps on enlarging in the size. So the container has to be with the joints so that the bones can keep on increasing because the skull size has to increase depending upon the increase in the size of the contents. So if the container becomes rigid right from beginning, that we see in the craniostenosis, so the brain gets signs and symptoms of raised intracranial pressure.
Definitely.
Yes, sir. Thank you, sir. Thank you for your comments.
Sir, one more question to Kshitij or Dr. A.K. Singh, sir. When should we fix with plates? At what age group? Should we fix them with titanium plates or we should not?
First of all, let me answer the question of Dr. S.C. Tandon, what he have just discussed about it, why it is common in the skull bone and not in the long bones. So, sir, to my experience, the most important cause of this growing skull fracture is not basically the linear fracture. It is basically the underlying tear of the dura. And because of the tear of the dura, the brain is pulsating and it is herniating, and that is why it is not, it is causing the growing skull fracture. And that is the reason. And you exactly told us in a different way, but the logic is the same. It is basically the dural tear through which the brain is herniating, and that is why it is the growing fracture, skull fracture is going on. And regarding the question which we asked, that the use of titanium plates or something like that. So what we do at our center, that whenever we operate the growing skull fracture, first of all, we never recommend the cranectomy. We always do a craniotomy. Take out the bone pieces, identify the defect, repair the dura defect with the pericranium, and then we split those craniotomy bones into different pieces and try to fix them all with some, the steel wire or, the vicryl or the sutures like that. And in due course of time, the periosteum is there, and due course of time, it basically grows there and cover the scar defect. So that's what we are doing.
My question was that the case which Prakash Khaitan showed, it's a normal depressed fracture and he fixed it with the plate that in a young child. Should we do it or we should not? It's not the case of growing skull fracture. In the normal young patients of 3 years or 1 year, if they have a fracture, so should we fix them with the plates or we should not?
I think we should fix it.
Beyond 3 years, the skull does not go much significantly in size. It doesn't cause much problem. The problem we can't extrapolate that to the spine. Spine is a different thing. That's still growing much larger. So therefore, that's a very small area. So it does not really lead to any bony abnormalities or thickness there.
Okay, sir.
But what you just pointed out just now is a very nice way that you can use absorbable or non-absorbable material for fixing them in place. The trouble only is that the fracture segments that you stitch with either a steel wire or non-absorbable material may not be as stiff as a screw plate would be. But then a screw plate also requires a much thicker bone. If you have a split calcareal graft, then you really can't use a steel plate or titanium plate.
So I think it is a matter of personal choice. whether to fix it with some non-absorbable suture or with plates and screws.
Yes,
Now,
both are valid.
Dr. Khetan, I just have a question for you. What, according to you, is basically the natural history of the groin skull fracture? So if you somehow don't treat a patient of a groin skull fracture, or if you advise surgery and the patient does not go for a surgery, then what is the natural history of such groin skull fracture if you don't operate it?
A good question, Dr. Chitej, you have asked. Basically, what happened if you are not treating it, patient may have problem of seizures in his coming age, or he has a problem of progressive neurological deficit, or he has impaired cognition. Like I have already so the hemiplegia may also occur. These things may be occur if it is not treated properly, timely, and meticulously.
The most important is poor scholastic performance.
What, sir?
Poor scholastic performance. That is basically cognitive and memory and learning abilities. They keep on deteriorating if you do not treat them.
Okay.
So, Dr. Khetan, as per your presentation, the take-home message for me is that whenever there is a boy, whenever there is a child of age less than 3 years, or some literature say it is less than 5 years, who came to us with a linear fracture, with the presence of a cephalohematoma, and if you're finding a bony diastasis of more than 4 millimeter, and if there is an associated underlying brain condition, always suspect that there is a possibility of a groin cell fracture. There are some literature, some reports, they even say that if there is an history of a seizure just after the trauma, then in those patients, the groin skull fractures are common. I have not encountered in my practice, but the literature suggests that yes, there is a possibility that if there is seizure, there can be an associate with the groin skull fracture. So whenever you are suspecting a patient that may develop the groin skull fracture, then I think the investigation of choice is the contrast MRI. And if you find in the contrast MRI that there is a dural tear through this, the brain is herniating, then always suspect that in due course of time, that particular patient may develop into a groin skull fracture. My last question to Dr. Khetan to you, that for how long, if you suspect that a patient, an infant with a linear fracture, and there is a possibility that it may grow into the groin skull fracture, then for how long you like to observe the patient so as to find out whether it will develop groin skull fracture or not? Is it 2 months, 3 months, 6 months, or a year? For how long you like to observe the patient?
Or at least for 8 weeks, it is given in the book. But we would like to observe every month in a follow-up for at least 6 months, sir. It is given for 2 months in the literature, but 8 weeks it is given. But I think it must be at least for 6 months, since there is sutural diastasis more than 3.5 millimeter is there. And one thing also you have asked about the seizure attack. There are 2 types of the seizure, Dr. Chitij. In genetic classification, in trauma, we have learned about the seizure. If there is early seizure due to any fracture, it has no significance. It always subsided within 3 months. We don't have to bother about the early seizures. If it is delayed onset seizure of any kind of the fracture, surgical injury, then it must be treated for a long time, and its cause must be diagnosed whether the underlying bone is glued or it is traumatized. So I think it is.
Okay, and in the chat box, I can see that one question asked by Dr. Vinod Tiwari, that regarding the role of lumbar drain in a patient of a groin skull fracture.
Sir, Dr. Vinod can ask directly if he is. Dr. Vinod can ask directly if he is here, because we try to make this session more and more interactive. So I want everyone should ask by himself.
To make some comments. I'm Dr. Rahul Gupta from Noida.
Yes.
Please allow me whenever there's time.
Okay, Dr. Vinod, you can ask, then after that, Dr. Rahul can also ask the question. Dr. Vinod.
Welcome, sir.
Good evening good evening to everybody. Right now, I am in Goa for my archery competition to be held either tomorrow or day after tomorrow. Well, Dr. Prakash, I want to ask a question that whether you can you can have any experience regarding this lumbar drain in these cases, and can you grade these growing fractures according to the by putting this lumbar drain, whether it is decreasing in size, or we can wait for any conservative measure for that one, or we have to do 100% surgery is required in those cases. Is there any grading like that?
The grading I already told you. There are three type of the grading of the growing skull fracture. First, in which dura mater is bulging. Second, in which arachnoid is bulging.
No. I'm
Leptomeningeal drain.
I'm yeah. If you do lumbar drain in these cases, so
Yes, sir.
many of the cases, what
Dr.
the
Binod
literature
sir,
is
I got your point. Sir, you are an innovative person
Okay, go ahead.
since our teaching. You have lots of newer things came in your mind. It is definitely a very good thing that came in your mind. We can put also a lumbar drain. It may be a part of treatment, but I didn't get anything in the literature about the lumbar drain. So definitely it is a very good question you have raised, and it may be, but chances of meningitis and all these things may be increased if we are giving any. I think Dr. Kshitij
I'm
and Dr.
asking that if you put
Dr. AK Singh,
if
your
put
comments,
lumbar
please.
drain in these cases.
No, lumbar drain is a temporary measure.
Sir.
You reduce the pressure. It'll make it
Sir.
easier for you to close the gap. After that, you'll have to remove. If you're using it as a bridge over therapy while you're closing your gap, fine. The pathology of the whole growing fracture is that there's a tear in the dura and the arachnoid, and the patient go out, and thereafter it starts forming a meningocele there, a local pseudomeningocele. Okay. Now, lumbar puncture is a temporary thing. You can keep it for 2 days, 3 days, 4 days. The whole process will not revert in 3 to 4 days. That's why you perform a CSF diversion procedure. That's the rationale for doing a shunt.
So, why I was asking this question, sir, after putting this lumbar drain, what I was told in my MCS time, that the CSF diversion from this cranial part to spinal part, that causes absorption at the level of spinal nerves. That might help in a low grade of this one growing fractures. Is it like that?
It doesn't work. It doesn't work.
Okay. Unlike
Never come across.
any other CSF leak, it may work, but not in growing skull fracture.
Okay.
Dr. Rahul, you want to ask something?
Rahul, please. Dr. Rahul, please.
Please unmute yourself. Dr. Rahul, please unmute.
Sorry. Yeah, during my MCH days and my days in PG as a faculty, we used to see at least 2 to 3 cases per month of growing fracture. Then at GB Pant Hospital, the number reduced to maybe one in 1 or 2 months. And now we rarely see in our practice. So is it with everybody that the incidence of growing skull fracture has reduced? I would like to ask the senior members.
Yes.
Or is it still very common?
Rahul,
No, it has reduced.
the time when you were undergoing training, the parents used to be a bit less bothered. Nowadays, with one child or 2 children, parents are extremely bothered. They would not allow a child to climb a tree or anything. So the injuries have certainly become much lesser.
So that is one of the reasons, sir, mainly because of reduction in the number of injuries.
Yes.
Because the rural background, still the injuries are so common, sir. So maybe we are not getting in the cities, but maybe at other places.
You don't get it.
We still found the patients of a growing skull fracture in our department.
You will find it in Lucknow. Noida is a high-end area, right?
Secondly, sir, with my experience, I would like to say some things, sir. Like in the pathogenesis, because of the receding of the dura and the arachnoid, it is mainly the bone is directly exposed to the pulsations of the brain. That is why there is a scalloping of the bones, and the bone also are twisted outwards. That is one of the reasons why this is happening. And in the natural course, if we do not repair it, there will be enlargement of the leptomeningeal cyst. The ventricles will start deviating towards that area, and that whole of that side of the hemibrain will become perished, or maybe gliotic, or maybe we convert into porencephalic cyst. So there will be hemiplegia, hemiparesis, and one half of the brain will totally get a defect. Secondly, sir, with our experience, we have never used plates in these cases, because when we have split the graft, we used non-absorbable sutures, especially ethibond in such cases. And these bones are quite, in young patient, they heal very fast. So if we are not too much bothered about the cosmesis, so usually they heal very fast, and we don't need to fix them very rigidly with the help of either steel wires or maybe even screws and plates. So that was our experience. And lumbar drain, we have put in 2-3 patients where we had some CSF leak. That was I wanted to comment on.
Thank you, Dr. Rahul, for your comments. And if no other question, then may I request Dr. Kankan to present, the certificate to Dr. Prakash Khaitan.
It was really a nice discussion, nice lecture on by Dr. Prakash Khaitan. He has elaborated everything about growing skull fracture. This is, I think, very new for me as a neurologist. So I congratulate Dr. Prakash Khaitan sir for presenting such a nice and elaborative lecture. And I also thankful to all our participants, especially our chairpersons, Dr. A.K. Singh sir, Dr. Kshitij, Dr. B.K. Ojha sir, and all other participants to make this event a grand success. Since we are on the virtual mode, so virtually I would like to appreciate the effort of Dr. Prakash Khaitan. We will give a physical certificate and a plaque during the annual meeting of UP Neuroscience Society at Lucknow. Whatever dates are going to be planned. So, Khaitan sir, you have to come to Lucknow in annual meeting to take your certificate of appreciation as well as plaque. This is your certificate of appreciation, virtual certificate of appreciation, because I cannot give you in physical form. This is only on virtual form. So this is also a way to invite you in the next virtual conference, next physical conference, annual conference. So please do attend.
Thank you, sir. Thank you very much for giving me such an honor and such an opportunity to give a chance to present this type of the illness.
Thank you, sir. I extend my sincere thanks to both of my chairpersons, Dr. A.K. Singh sir, Dr. Kshitij sir. I would also like to thank Dr. Amit for moderating this session. He's sick today, so probably he's not here right now, but he has joined with due diligence. So I thank you, Dr. Amit. Thank you, everyone. Thank you, Dr. Kshitij, Dr. A.K. sir, and thank you all participants. This session was live on YouTube, so I think a lot of viewers were also there. So we will continue this activity. Then we'll definitely meet next second Saturday, 7 to 8 p.m. with some new topics. So I request also to all these postgraduate departments to share these links to their students so that they can also join. If they had joined today, they would have definitely got a lot of new points, lot of learning points with this growing skull fractures. This is for neurologists, neurosurgeons, topic for neurosurgeons, but neurologists also get benefit with these topics. They also know what is going on with the neurosurgery. So thank you, everyone. Thank you very much. So with this, I am closing this session. Thank you very much.
Thank you, everyone.
Thank you.
Thank you, sir. Thank you very much. Thank you for joining.
Thank you.
Thank you, sir. Sir, it is.
Yes,
Sir, you can just. Thank you.